So, hi, good morning. Brooke Trainum. I'm with the American Psychiatric Association. So thank you for coming here today. We're really happy to host this roundtable today with our partners at CTeL. Chris and I have worked together for many, many years on telehealth issues. So it's really wonderful. This really came about at the end of last year when Chris and I were working the phones at the end of the year, trying to make sure this extension got passed. So we thought maybe we'd start a little earlier this year and not get to the last minute again, thinking about what a partnership could look like, a strategy, and how to move forward. So again, thanks for being here today. We hope this is the first of many conversations as we move forward to get a final rule or something passed here in the future. So again, thanks. And really quick, bathrooms, if you just go out here right down the hall, there's also a break room area if you want water, tea, any other.
And then we have some water.
Water's over there.
as well.
Please help yourself to some snacks as well. So thank you.
Hi, everyone. I'm Krista Natoli. I'm CTeL's Executive Director. CTeL stands for the Center for Telehealth and eHealth Law. We're a 501c3 nonprofit research institute. We focus on all the laws, policies, and regulations that impact the delivery of virtual care. And we are so grateful to APA for our partnership today and for all the previous years that Brooke and I and APA have worked together. This meeting is very selfish. Brooke and I joke that on December 24th, if we're calling everybody at HHS and DEA and working on Christmas Eve, something went drastically wrong. So our goal is that we want to have a conversation. We want to collectively, this will be essentially the kickoff. We anticipate there'll probably be another conversation and another strategy session to come. But the goal is to figure out where are we on December 31st. What is the strategy way before that? And how could we work collectively together to make sure that we at least have at the bare minimum a communication strategy. So if we know that it's likely going to be an extension for another year, we're going to be able to communicate that with our members, our hospitals, our health systems, our pharmacies. So we don't have absolute chaos and concern about can we prescribe or can we not prescribe, because there is such severe federal penalty that attaches to that, and criminal penalty. So with us, here you have introductions. We're running a few minutes late, so we'll try to catch up on time. But why don't we go ahead and just do roundtable introductions, and we could begin with our speakers.
Hi, I'm Beth Conley. I am with Winning Strategies Washington, formerly with the Office of National Drug Control Policy.
I am Scott Brinks. I'm the owner of Brinks DEA Consulting and formerly with the DEA.
Hi, I'm Megan Gilmore. I'm the Vice President of Government Affairs with the Association for Behavioral Health and Wellness. Our members are health plans that cover and manage mental health and substance use disorder benefits.
Hi, I'm Caitlin Galuli. I'm the Director of Behavioral Health and Quality Policy at the American Hospital Association. So we represent the hospitals, but also in psychiatric facilities and everybody works in them.
Hi, my name is Maria Curl. I'm a senior policy analyst with the Public Safety and Legal Counsels team at the National Governors Association.
Hi, I'm Alana Gordon. I'm the Advocacy Policy and Practice Management Coordinator here at APA.
Hey, good morning. My name is Steve Postal. I'm the Senior Director of Policy and Regulatory Affairs at the National Community Pharmacists Association. So we represent the community pharmacists.
Hi everyone, Robin Tesson. I'm a Director of Payment Policy with the AHA here with Caitlin.
Morning, everyone. Corey Wetzel with the American Pharmacists Association. I work in regulatory affairs there and represent pharmacists, student pharmacists, and pharmacy technicians in all practice settings.
So Al Haidari, I'm the Director of Digital Health here at APA.
Amanda Rosner, Policy Advisor at the American Pharmacists Association.
Erin Gilliberty, Chief Public Policy Officer at Mental Health America. Alexa Abel, Government Affairs Director at the National Rural Health Association. We represent really anyone involved in or interested in.
Hi, everyone. Sophie Fisher. I'm the Membership and Operations Director at CTeL.
Hi, I'm Lydia, Policy Analyst with CTeL.
And then we have some great folks online with us.
I'm Abraham Barton. I'm the CEO at FastSite. We work with rural federally qualified health facilities and community behavioral health centers. We also provide services to recovery centers that use Suboxone. So nice to meet everybody.
Hi, everybody. I'm Jennifer Sheets. I'm the CEO for the National Alliance for Care at Home. So we represent about 2,000 home health hospice providers, around 11,000 locations serving the Medicare beneficiary population, and about 4 million patient lives.
Morning.
John McMahon.
My name is Randy Little. I work with FastSite. And as Abraham mentioned, a little bit of background about FastSite. I am the CFO for FastSite. Thanks for glad to be here.
Good morning. I'm Karen Ferguson with the American Academy of Child and Adolescent Psychiatry. I'm the Deputy Director of Clinical Practice. And also with us today, I just wanted to introduce Dr. Court Byrne. She is our Resident Advocacy Scholar for the month of March. And so I want to welcome her as well. Dr. Byrne, are you?
Thank you, Karen. I'm here.
Great. Thank you.
Hi, everybody. I'm Jess Easterday. I am the Director of Virtual Care at Amplify Health, located in La Crosse and Green Bay, Wisconsin.
Joe McManaman, private practice lawyer, Christian Barton, Richmond, Virginia. Good morning.
Nora, we couldn't hear you. While you try to do that, I'll introduce myself. Hi, Hannah Wesolowski. I'm Chief Advocacy Officer at NAMI, the National Alliance on Mental Illness.
Okay, I switched microphones. Is that better?
Yes.
Woohoo! Okay, my work here is done. Just kidding. I'm Nora Cox. I'm the CEO of the Texas eHealth Alliance. We are the Digital Health Advocacy Association at the Texas Capitol.
Is that everyone online? All right. We're going to hand this over to our speakers now. Scott Brinks and Beth Connolly and Nora Cox. Just going to do a quick legislative and regulatory update, a little history about how we got here. And Scott, why don't you, is it Scott, you're going first, or is it Beth?
Either one, that's fine. Okay. All right, well, I'll give you a little history about it and then my background. So my last 7 years I was a diversion investigator at DEA, so I did investigations on doctors and pharmacists, stuff like that. But my last 7 years, I was the section chief of DEA's regulatory drafting and policy support. And I was, and don't blame me when I say it, I was the one that wrote the special registration rule and all that kind of stuff. But there's a lot more than just Scott did write it himself. There was a lot of influence in it. Okay, so yeah, that's my history. We had 30 attorneys in the regulatory drafting section. We drafted all the regulations for DEA. So anyway, this special registration mess began with the Ryan Haight Act, many years ago. I believe it was in 2008. It came because of all the online pharmacies for opioids. The Ryan Haight Act was extremely successful. Prior to that, we were investigating online illegal pharmacies constantly. Once the Ryan Haight Act went into effect, I never once investigated a illegal pharmacy again until DEA started investigating them again when the COVID happened. So that's where this all started. So throughout there, the Ryan Haight Act said DEA had to write regulations on the special registration, and obviously they did not. It took them a very long time. 3 times throughout the process, DEA was told by Congress to do it, and they did not. I came as a regulatory drafting person in 2019, and that's when we really started to work on the special registration. Prior to 2019, the special registration was going back and forth in DEA. There was so much conflict on, they didn't want to start these, like the opioid epidemic with all these online things. There was all kinds of stuff in it, like a 20 patient limit per doctor. I mean, it was, when I saw it for the first time, I'm like, there's no way that this will work in the medical community, the restrictions. Well, then COVID happened, and that changed everything for DEA. It was the worst first month of my life at DEA because I worked so many hours because we had to make all these exceptions to regulations, because of the Ryan Haight Act, to not have an in-person visit or anything like that, just basically open it up. Well, it opened up, And obviously, some bad actors did pop up. You've seen it in the news. And then DEA became concerned again. But we really pushed forward to do the special registration. We had a really good product ready to go. And then the administration, there was a change in administration, a new administrator. And then that's when we published that referral thing that you saw. That was not supported by DEA diversion at all. It was not written by them. It was written by outside of actually DEA diversion, the experts of it. So that came out. Then I had the second worst month of my life was those 36,000 comments that everybody sent in. But we went through all 36,000 comments and we did it in the 30 days we were supposed to. And we realized, you know, obviously the administrators then like, this isn't going to work. So then they held the listening session. That was huge for the administrator. That changed a lot of things. It was an excellent thing that happened. And then we decided, you know, this referral special registration thing, it really wasn't even a special registration, was not going to work. So then we put together the next special registration rule. And this is when it became very political because DEA was being controlled by a lot of other agencies. The Domestic Policy Council, HHS, ONDCP was a part of it then because this was during the Biden administration. The VA was huge because the VA wants to be able to do telemedicine for everybody for any reason, not ever see them. I mean, it's great for their business model for the VA. So there was a lot of politics in it. And then we published the special registration. It had all those restrictions in it, which everybody knows, you know, you can't, for Schedule IIs, you can only prescribe in the state where you are. 50% of your patients can only be on telemedicine. The other 50 have to be regular. It had the huge thing in there about these telemedicine platforms registering with DEA, which is a huge legal issue because the statute is very clear. You only have to register if you dispense, administer, possess, or distribute controlled substances, which those platforms do not. It's the actual doctors who are the DEA registrants. So this one came out with all kinds of problems, but DEA's this, and then I left DEA right around this time. But DEA was quite surprised at how few comments they got, you know, on this one. I mean, there's pretty easy, the problems in it. And that's kind of where they're at right now. I don't think they really know what to do right now because the product was so politically pushed out and will not work for industry. Their options right now are either to publish a final rule based on what they have and make some changes, or they have to put out another notice of proposed rulemaking, which is going to kick this down the road another year. So that's kind of the real basic quick history of this whole thing. Beth.
Oh, thank you. I can tell you that Scott and I just met a couple weeks ago and we came, Scott was at DEA when I was at ODCP and I'm like, really, that's not how that happened because we were at different meetings at different times and we never met. So my perspective might be a little bit different because just of the places that I sat, I was with the Domestic Policy Council folks at the table with HHS leadership and with the DEA administrator and leadership from DEA. And so there was a lot of back and forth. ONDCP's main concern was, of course, the buprenorphine and making sure that buprenorphine was readily available. CDC had done a number of studies looking at both buprenorphine and methadone, found no diversion, a little to none, no more than what had been really diverted when people had to go in person every day for methadone or for buprenorphine. So the research we found was very clear. And so we were trying to urge DEA to write a rule that would pretty much keep intact what we had and what folks had been, the lives they've been living through COVID because they had been easily accessible for their medications. The adherence to medication was known to be very good. And so there was a lot of back and forth between HHS, DPC, ODCP, and DEA, with all of us on one, literally all of us on one side of the table and for DEA on the other side of the table, really arguing and trying to get to right the ship so that we had a place where folks could prescribe and patients could get what they needed in the most efficient and effective way possible. So, and we know that the DEA rule came at the very, very end of the Biden-Harris administration. Joke, and it is my joke, with folks at the Domestic Policy Council at the time that they were just waiting everybody out. right? They wanted to publish something and they were just waiting everybody out because they knew that with the change of administration, then there would be new eyes. And I think Scott and I have talked about the fact that now it seems everything is sort of just stuck. I don't feel that there's, and this is a personal opinion, just watching everything that's going on, you know, with the folks that have all left both departments, both agencies, HHS, ODCP, and DEA, you have lost a lot of, there's been a big brain drain. So you have nobody, not really folks with no history, but also no urgency. Folks are sort of, other things are taking, especially at HHS, other things are taking sort of this wind out of this sail and putting it into other sails. So that's one of my worries is sort of the inertia around this issue that we're not going to get as much attention as we really need and get people to listen.
Yeah, and I want to follow up because this is great because now you're going to see how government is ineffective in this kind of thing because you know she talks about the statistics that show that it wasn't really diverted. First of all, me in charge of regulatory drafting was never provided those statistics, so I did not see them. What we were coming from was a whole different angle of diversion because DEA is a law enforcement agency, not a regulatory oversight agency. They have a small portion of that. So DEA is always thinking in the law enforcement aspect, you know, so we look at diversion a whole lot different than what the regular world looks at diversion, because I believe that the diversion defined by how ONDCP and them was, it did not include if you gave it to a friend, because you were helping a friend. Is that not right?
So that was, so NIDA and CDC, so they are responsible for all the data, and they were, and that is definitely one of the diversion, definers, if you will, is there's different types of diversion, right? There's one that's illegal diversion, you're making money off of it, and then there's diversion because of lack of access. And so for buprenorphine, that was one of the, but all of the, a lot of the was just basically also looking at, because we had increased access. It was easier for people now to receive buprenorphine. So there was less diversion because when it's easier for me to get it, I don't have to rely on you to split yours with me.
And then see, there it is, diversion in DEA is if it went away from who it was prescribed to. It doesn't matter if it went to a friend, why it went to a friend or anything. So now you can see the difference in why it's growth, the problem is growing there, you know, because DEA is like, what are you talking about? It's not being diverted. They're giving it to their friends, they're giving it to their family. This is diversion because theoretically giving a controlled substance to your family member, whether it's a payment or not, is illegal distribution of a controlled substance. So you see how DEA looks at it, where the health world looks at it as they're helping this person get off of. And then there's people like me where I have a daughter who has a drug problem, and she's telling me constantly, Dad, when I was in jail, the biggest drug that was easy to get in there was Suboxone. We were selling it back and forth in jail to each other. You know, so now I have a whole different opinion. I'm not getting the information that you guys have. And this is why regulatory drafting is very hard, because the right people aren't connected. And that's probably a lot where DEA is right now, because now there's all new people that they're trying to connect with, you know, like, because I remember talking to somebody at regulatory draft and they're like, I don't even know who to talk to at HHS anymore. You know, they're all new. So this slows down the whole process. And I agree with Beth is, I don't see a path forward for the special registration. We're going to be doing another extension. That's, in my opinion, how I feel. Does that kind of make sense of where all the struggles are in regulatory drafting?
I'm glad there was a question about the term diverted, because I feel like that was something I wanted to ask, and there wasn't sure that was like a reasonable question, but yeah. So.
Do you have any, what are your thoughts about that? Or you want to jump right into the research?
Do you want Nora to?
Oh, Nora, there you are. Sorry, yeah, I do want Nora to speak.
With a working microphone, right? So first of all, I want to.
Picture wasn't up on my screen, but it's up there. Okay, go ahead.
All good. All good. Can y'all hear me?
Yeah, we can hear you.
So first of all, I want to thank Scott and Beth for their candor. Like, we have to be able to talk about what's going on in the interior of these agencies, and it's getting more and more opaque. And I think that makes all of this really hard. So just listening to the back and forth between the two of you, for me, that's really helpful. I sort of have three observations to make. The first of which, in case y'all didn't know, the first people that DEA went after on Ryan Height, when they decided to enforce it again, were in Texas. Whereas one of our was called Spindletop in East Texas, which was a center providing services to folks with mental illness. And that was quite dramatic because there hadn't been enforcement, and all of a sudden there was enforcement, and everybody was very upset because it was perceived here as taking away access. So that theme has sort of continued right through my stakeholders. But here's the problem that you may have, and I know that this is what Krista likes for me to bring to the table is the state perspective. I have a state senator who wants to mandate in-person visits for all of these prescriptions, period, the end. And we have fought her and killed it and killed it. And the longer it takes for there to be a federal solution, the more capital she's accumulating, that the federal government is not addressing this problem. So she needs to address it. And thank goodness we have a big coalition to sort of push back against her. And I think we're in good shape from keeping an absolute in-person mandate from happening. But she got really close to passing it in 2023. She got so close, she tried to get me fired because she perceived me as the sole obstacle between her and what she wanted. I wasn't. We had a lot of people, but she focused on me. I had to go into witness protection for a while because she really does think that without action from the DEA, people are going to die. And she's looking at that one case from Cerebral as something that is endemic through the system instead of perhaps a one-off, that if they had done some different things, like checked medication history, checked SureScript, stuff like that, maybe that wouldn't have happened. So we really run risk, not just from not having a federal solution, right? Even if we stay in the waiver, that's great. You're going to see state policymakers over time saying, well, if Washington is too dysfunctional to solve this, we're going to solve it ourselves. And we're going to run the risk of a 50-state patchwork, like we have for telehealth with the medical boards, like we have for breach notification, that sort of thing. And then the other thing I just want to mention, and I know my co-panelists know this really well, the other half of the industry that I work with is electronic health records and health information exchange. And so for a while now, we have been seeing bad actors getting into SureScripts, getting into Dr. First, stealing NPIs, issuing false prescriptions. And this is bad diversion, to get back to that distinction that y'all were making a few minutes ago. This is really problematic. I mean, I don't know who decides I want to be the IT guy for the cartels, but we are certainly seeing sort of organized behavior here, systemically coming after weak spots in these electronic systems. One of our kind of leading pain management doctors in Texas had his NPI stolen just before the holidays, and it created a whole brouhaha. So there's an agent out of, I think, Arizona from the DEA who's been coming to EHR conferences, and she's been saying, hey, we need you guys to be our partners and help us. Because if you think about it, being in a digital space, we ought to have better audit trails, better records, checks against NPI theft, which I know is something CTeL's talked about for a really long time. So I am hoping whatever strategy we craft here, that we can get the Electronic Health Records Association and HIMSS and other groups nationally to stand with us on whatever's proposed, because they're actually at risk also if we don't get to some regulatory clarity here. We've got some criminal behavior, we've probably got some lazy, uneducated behavior, and none of that is good for us having a unified front to policymakers to say, this is the way telehealth and controlled substance prescribing ought to interact. Not any of the ways we've tried before. We've got to find something that's going to work, but apparently not this year, which makes a lot of sense to me given the hot mess that we have going on in DC. So that's just a little perspective from the state side that Krista wanted me to offer up as part of the discussion today. And I'll stop there.
I have kind of a follow-up on what Nora said, because she brought up the telehealth companies and you want the backing for this special registration and things like that. There's a divide that was caused in this special registration that not all of them are going to help, because if you have Schedule 2s, it makes you almost impossible to do telemedicine. If you do Schedule 3 through 5s, that's a very doable thing to set up. So these telehealth companies that are only prescribing Schedule 3 through 5s are A-OK with the special registration just how it is, because it doesn't affect their business model. Where the Schedule 2 companies, which a lot of you guys are part of, would be involved in, is they don't want this because they're not. You can't have a Schedule 2 telehealth company where your practitioner has to have half their patients as regular patients. The whole thing doesn't work. So they've divided the associations, not on purpose. I know that wasn't on purpose, but it just happened by how this rule is. So you have half the associations that are good with it and the other half aren't. So you can't get a consensus with everybody, so.
Well, and can I add something on top of that? In Texas, we have swaths of our state that have no capacity for in-person visits for psychiatry, for example. So we are 100% virtual. So we tried in 23 here in our legislative session to do exactly what Scott was just describing, which is figure out sort of how to get to the companies that were fully virtual. And then it turned out that our safety net was fully virtual in large swaths of Texas. And so trying to figure out how to make that work when I have such a provider supply problem that my East Texas psychiatric safety net is 100% virtual and primarily run by our academic health science centers and our universities, not private companies. So when you start to dig into this stuff and you start to make those distinctions, I understand that that divide was not necessarily made to be on purpose, but I also suspect no one was thinking about there might be a safety net that's government run that's 100% virtual, but that's what we have because we have such health professional shortage areas in Texas. And it just makes all of this, which was hard already, even harder, I think.
Nora, I'm glad you talked about the state perspective and the fact that states are in many cases taking a more restrictive policy. We saw it in New Jersey recently, where New Jersey, and that, you know, we don't know if that will change. That was done by the outgoing governor, but states are concerned that the federal government is operating off of extension after extension, and there's these opioid epidemics, and they want certainty for their prescribers and they want certainty for their patient populations. We could argue if that's correct logic or incorrect logic, but ultimately this is going to cause a lot of misinformation and concern, not only among the prescribers, but also among the pharmacists who are really intentioned to be the last gatekeepers. So you have patients that may or may prescribed by a telehealth provider. Let's say they get to that point in scenario one, and then they go to the pharmacy and they go to a retail pharmacy and they can't get their prescription filled because CVS or Walmart just alerted that we don't fill these prescriptions by telehealth providers. I mean, that's option one. Option two is that, you know, states are becoming more restrictive, and that memo didn't get to the prescriber. And now they're not in violation of federal law, but they might be in violation of state law. And we have a lot of individual small SUD practices and companies that might not have, you know, GR teams that are communicating this information to them. And so it just causes this level of chaos. And Scott will tell you, and so will Beth, that, you know, there's criminal and penalty that goes along with prescribing a controlled substance that you're not authorized to do. And Nora, you see it on a state level, the absolute confusion that happens within hospitals and health systems. And not to mention our direct-to-consumer providers that, you know, that's a whole other beast, because some of these companies are just designed to prescribe medication, and a lot of times their legal counsel might not be getting the most accurate information to their doctors because of the 1099 relationships that they have.
And she just kind of brought up another huge hurdle with the special registration. Let's say that you guys get the special registration however you want it. It's the best product out there, and it's the final rule. The problem at the pharmacies is the pharmacists have a corresponding responsibility, and they have to get rid of all the red flags. One of the red flags is their patients travel from a long distance. Another red flag is doctors are not in the same state. These are all red flags that DEA won't change. So this is why you see some of the bigger hospital systems, or not hospital, bigger pharmacy chains just saying no to telemedicine. Because you know what? They paid all those big fines in the MDL, multi-district litigation, for not doing their corresponding responsibility. So now they're like, wait, we just paid a huge fine for not following these rules. Now there's telemedicine, and we're not really following these rules if we fill these prescriptions. What are they going to do to us now? And this is why you're getting pharmacy chains saying, no, it's a liability issue. We're just not going to do it. That's just the easiest way to do it. So even if a special registration does publish a final rule, we're not out of the water yet to make this work.
Also, I think you and Nora both made a really good point. In that this administration has really pushed more decisions to the state level. And so this is an easy one to just sort of punt down the road and say, we'll continue it for another year, continue it for another year, and the states can figure it out.
Right.
And that's where we're going to have, I think Nora said, the patchwork of what, if I'm in Texas or I'm in New Jersey, or, if I'm in Minnesota, what is the difference? And, and if you have large, hospital systems that are through, many states, this becomes very confusing. And it'll start to shrink, all the access.
I mean, most health systems have more than a one state footprint, and most direct-to-consumer companies have a multi-state footprint. You can see how quickly this gets out of hand. And the direct-to-consumer companies that we're aware of that prescribe controlled substances oftentimes have a 1099 relationship with their prescribers. There's lots of different reasons to do that, but ultimately, if their license is called into question because they prescribed in a way that was in violation of state law, they now have to take on the legal and regulatory liability of that. And oftentimes medical malpractice insurance doesn't cover it. It doesn't cover these instances that have to go in front of the regulatory boards, or and that in itself is very costly. And we have known of providers who have ultimately gone seriously in debt because they were trying to clear their name and clear their license. So there's a heavy financial responsibility that goes to the prescriber if for some reason they are operating off of misinformation unintentionally.
Joe's hand is up.
Joe, go ahead. Joe McMenamin.
Thanks, Krista. Just briefly, lest I be accused of a different form of diversion from the actual topic, namely this theft of NPIs has consequences beyond the misuse of controlled substances, in that it can also lead to reimbursement problems and to fraud and abuse. I know that from firsthand experience of a client who had a very rough time as a result of such a theft. So it's all the more reason to be cautious about the use of these numbers and to take steps to prevent their being misappropriated, misused, stolen, and otherwise used as a club against the person to whom the NPI is ascribed. Thanks.
Joe, there might be people in this room that might not be aware of the problem with NPIs being stolen. Can you give just a 30-second background on how that could happen, and maybe how differing state laws and regulations could lead to opportunities for theft?
Well, without claiming to be the world's authority on this, the number is crucial for a lot of reasons, not the least of which is reimbursement. And when a bad guy has possession of a legitimate prescriber's NPI number, he or she can use that number to bill against Medicare and other federal healthcare programs, and indeed in some instances commercial carriers as well, for services not rendered by the perpetrator, or perhaps not rendered by anybody, diverting, to borrow the phrase, dollars to the wrong source. And it's a significant source of fraud and abuse that we don't currently have a very good answer for. It's relatively easy to acquire these NPI numbers. In fact, it's available online, and you can steal them and use them at will, and has funneled off money that should not be used for such purposes, obviously, to great expense of the public fisc, and further erosion of the trust that I suspect is not at its zenith nowadays between the public and health professionals.
Probably. Go ahead, Nora.
Oh, I just want to mention one more thing, Krista, about the 1099s. I can't speak to other states. I think we may be the last one standing, but we're a big state. Doctors in Texas have to be on 1099s. We do not have employed physicians. We have a ban on corporate practice. So when we tried again in 2023 to calm Senator Campbell down, one of the things we couldn't figure out was how to increase at a state level the accountability we kept saying, well, it's got to be the doctor's license because they're on a 1099. And she kept saying, I want the company. I want the company. I want to go after the company. Well, when you have a prohibition on corporate practice, you're supposed to have separation for that independent medical judgment that the doctor is using to write that prescription. So there was a lot of opposition. She got very frustrated, as I mentioned. She was not a happy camper. She's still not a happy camper, although I think we've got her in a better place than she was. So for my state, that adds a layer of complexity because there are downsides to a 1099 relationship and there are upsides to a 1099 relationship. And then I know I've heard at CTeL meetings that sometimes telehealth companies hang on to the NPI and keep billing under it, even when that physician has actually left that specific company or practice. So this is an area of vulnerability where I think some work needs to be. Maybe we need something that looks like LifeLock for NPIs so people can audit the activity that's being done under their NPI. I know I've heard that idea tossed around over the years, but it's definitely a vulnerability in the system and it's problematic.
You bring up a fantastic point, Nora and Joe, is that NPI fraud is rooted in financial fraud, but there's an impact on the prescribing of controlled substances. If you are going to commit these fraudulent financial acts, what has so much prescribing controlled substances in a way that is inappropriate has more value than, or just as much value as durable medical equipment. So if we're looking at what is a way to prescribe inappropriately, prescribing controlled substances has a lot of street value. And there are financial incentives and kickbacks that happen with that. And so we might be looking at a reimbursement issue at its foundation, but ultimately it leads to diversion. And it's a pathway to do it.
Scott and sorry, this is kind of moving away from that, but you both mentioned data, and Scott, you were basically like, we never saw it. Beth, you said we had this, and this may lead us kind of into the next part of the discussion, but how do we ensure that the data is getting to the right people within the agencies or and a second part of that is, and as we were just thinking about the prescribing and NPIs, but where do you also see the role of AI coming into this rule or something? Because I mean, we've already seen in Utah some potential legislation around AI prescribing and not controlled medications, but that is the path, right? Potentially. And we all say, well, that can't happen. They don't have an NPI, but it can, right? And so just also wondering how does that potentially play in or where maybe, I don't know if you have any thoughts on that.
I can start about the data. So I can say it really depends on, does the data get to the people who need it? So here's Scott trying to draft regulations. We at ONDCP, and I was at the table when HHS handed over to the administrator all the work that CDC had done and all the work that NIDA had done. I was at the table with Nora Volkol when they were talking about all the data with the DEA leadership, yet poor Scott has no access to any of this. And he and I were talking about one of his former colleagues, who also, I'm like, you can tell me this, but I need the data. Give me your data back. And I go, we really don't have any data on this. And I'm like, okay, both things can be true. So I think one of the things is trying to figure out the leadership has to also share down, right? And we would share widely, and CDC published all their research online. There were a number of other organizations who received a lot of funding during COVID, who were offered by their grantors. The grantees were allowed to sort of pivot their research to really look at this natural experiment that had come, during a time when you can prescribe remotely, and folks did not have to have an in-person visit and all of that. And all of that is available online. So it is either people are not being given the data, but also that means leadership is not offering it or demanding or asking their staff to actually look at that. And I think it could be, no offense to again, it could be a byproduct of different agencies, right? HHS steeped in, researchers, NIH, CDC. So it's part of their being. ONDCP, we were a small agency, but filled with researchers, and often working very closely with NIH. So I think it also is part of the culture of the agency. Are these agencies that are used to consuming or providing, doing their own research, for also being on the consuming end of trying to make sure they had it. But it's definitely getting it to the people who need it most. And there, it seems like if there's lots of players, it gets stopped somewhere.
Yeah,
I'm curious to ask a question. When I was at HHS, I was on a reg writing team, and people came in and met with us.
Yes.
Like, they asked for a meeting and they walked us through whatever it was they wanted to say. Now, of course, we were in reg writing mode. We weren't responding. We were just listening. And did you have that capacity to, because some agencies, in my experience, don't do that. Like, they're like, I'm in reg writing mode, go away. We did allow people to come in, meet with us, and lay out their arguments. I'm curious what the process was in going to this point of whether we can request meetings and those would be well received or not, depending on agency culture, it seems to me. So I'm curious.
When I was there, we wanted to have meetings, nobody asked.
Nobody else.
We very rarely got requests for meetings.
And we had the same, that certain groups would ask and others would not, and we granted to those who asked. That's very helpful.
Yeah, and I'll follow up on the research with that thing. At DEA, it's all, research is very expensive to do. And the DEA diversion program is not funded by tax dollars, it's funded by the registrations that doctors pay. Well, DEA for years has been in all kinds of problems for how they spend that money. And during the Biden administration, a lot of that money was spent for the fees that doctors paid going after fentanyl across the country. Well, the problem is that's illicit fentanyl. That's a Schedule I. You can't really use doctors' fees for that, but DEA did it. Now, DEA has that big push for fentanyl-free America. That's being paid 100% by doctors' registrations. It doesn't really even apply to your registrations. It has the word fentanyl, so they think Schedule II, so they spend the money on it. So there was never the money. I pushed to do research when I was at DEA, but there wasn't the money or the funds to do it because those funds were being spent elsewhere. So we did not conduct any research ourselves. It was what people provided to us or what we could find online. That was the extent of our research.
Until CTeL.
Until CTeL did it, and then you presented it and DEA wouldn't take it. Yes, so yeah.
Well, that's a kind of a beautiful segue into the next section. So, so we're heading into section 3, which is a group discussion on CTeL research and intelligence sharing. Just to do a little bit of stage setting, we met with DEA. We actually met with Scott and his team. And we've worked with Scott and his team for many years prior to us doing the research and one of the things that DEA said to us and ONDCP is that we need data and we need research. So DEA did request that they wanted some very specific questions answered through research. And so we put together a academic study that has recently been published in September of 2025 in the Journal of Internal Medicine. Lydia is going to talk about that research finding, and then she's going to hand it off to Sophie that's going to talk a little bit about some additional research that we did looking at state policy.
Great. So I'll talk a little bit about some of the research we did, why we did it, and what we found. And so we started this research project after a meeting with DEA rulemaking officials in August of 2024. This was as they were getting ready to publish that second proposed rule on the special registration. And we had a meeting to figure out what their needs, data, evidence, and what they need to make an informed and evidence-based rule on this issue. And one of the things that they brought up was what Scott had mentioned, was this issue surrounding how we are defining and measuring diversion, and how that is in turn affecting the data that's being produced. There was a sense that the current body of research around this issue was insufficient for the agency's rulemaking. And so we came back from that meeting. We met with some of our research team as well as some of our research partners at Charm Economics. And we put together a study to better evaluate the impact of telehealth access, and overdose rates. We decided to use overdose rates and telehealth access as a sort of natural experiment, rather than trying to set up a more direct experimental method, given the limitations of the public policy around the issue. And so we selected 2 pairs of contiguous states. That way they were and similar demographics and characteristics. And the 2 state pairs we selected were Kansas and Missouri, and Illinois and Indiana. And the main variable that we looked between these 2 states was where one had implemented telehealth payment parity laws, and one of the state pairs had not. And so we used telehealth payment parity as a sort of proxy for expanded telehealth access. There's a lot of evidence to suggest that telehealth payment parity laws, by ensuring adequate reimbursement for telehealth services, results in a greater volume and accessibility of telehealth. And so using that as this sort of variable, we then compared the monthly overdose rates, using, again, payment parity as this natural experiment, specifically using a difference in difference analysis, in case you're into the specifics of that. And so what did we find? The graph on the screen are some of our main findings. It's a very short paper. It's only about 2 pages. It was published this past September in the Journal of General Internal Medicine, as a sort of concise but novel look at the impact of telehealth access on overdose rates. And the main insight that we got from this research was that the states that had implemented telehealth payment parity laws and thus had greater availability and access to telehealth services had a statistically significant decrease in overdose rates. We saw this in both pairs of states where one had telehealth payment parity and one had not. And in both instances, there was this statistically significant decrease in overdose rates. And the lead researcher on this was quite surprised by how consistent we saw between these 2 state pairs, and how significant of a difference there was. And so once we had these findings, we had it published in the Journal of General Internal Medicine. We first went to Congress. We held a briefing at the Capitol for congressional staff. We held it with Scott as one of our speakers. And we went over our findings as well as some of the history of the special registration, Ryan Haight Act, as well as Congress's role. And most importantly, highlighting the issue that Scott had also mentioned of Congress's repeated instructions to the DEA to issue this regulation that were ultimately ignored. And so we presented our research, we presented some background on the issue, and we got a lot of interest from some of the staffers who attended, who felt they had a better understanding of the issue, and most importantly, what Congress's role is in making sure that these regulations go forward. We also sent this to the new leadership at the DEA in their diversion control division. We sent this once upon its publication, and we forwarded it and bumped it to them again recently. And they have acknowledged that they've received the research. We've sent the full paper to them. They've acknowledged receipt, but they have not responded to any of our requests for a meeting. And so while there may have been under previous administrations, not a lot of requests for meetings, now we're requesting meetings, and we're not getting much back in terms of whether or not they want to take a meeting to discuss this research or what its implications may be for their special registration rulemaking. But I think, again, the main point that we want to highlight with this research that we've been highlighting with congressional staff we're meeting with, as well as with DEA officials, is again that we see that increased telehealth access has shown to correspond with a decrease in overdose rates. This is something that we have measured statistically significant across multiple state pairs. And we believe that this should play an important role in underscoring what the agency needs to know about the role of telehealth in prescribing, and especially when it comes to the agency's probably top concern, which is overdoses, which is stopping these overdoses and the diversion associated with that. So that's a little bit about some of the research we published. I'll turn it over to Sophie now to talk about some of the policy research we've been doing as well.
Hi, everyone. So I am CTeL's Membership and Operations Director, but I am also a JD, so I've been doing some legal research at CTeL. We publish 50 state surveys for our members that just give an overview of policy differences state by state. We do these on a number of topics. One of the more recent ones we've worked on has been an overview of telehealth prescribing of controlled substances laws. So that research report will be coming out shortly. It is still in final editing stages, but I am going to share a little bit about what the research found. So we looked at all 50 states, DC, Puerto Rico. We examined controlled substance definitions by state, telehealth prescribing authority, schedule specific prohibitions, comparison to federal law, and medical board guidance. The bottom line is that all 52 states or all 52 jurisdictions permit some sort of controlled substance prescribing via telehealth, but the rules can vary widely. Some rules pretty much perfectly mirror the Ryan-Haight Act. Some states are significantly more restrictive. So I was going to talk about the federal baseline a little bit, but that's already kind of been covered by other speakers. So I'm gonna just move on past that. Key patterns that we found are that Schedule II substances are the most commonly restricted, Schedules 3 through 5 significantly less so. And those restrictions can vary. There are restrictions around in-person visit requirements, for example. There are restrictions around which modalities are acceptable, whether that's audio, visual, just audio. And there are variations around exceptions. So for example, in some states, telehealth you can only prescribe via telehealth if you are in a medical facility. So for instance, if you are in inpatient treatment, you can be prescribed via telehealth. Opioids are also obviously commonly restricted, especially in states that were hit especially hard by the opioid crisis. You can see on the map, the states in red are those that are more restrictive than federal law. Yellow states are not necessarily more restrictive, but have odd conditions. And then the green states, which is most states, are no more restrictive than federal law. So for example, some of the states that we looked at, Alabama, you have to have an annual in-person visit as opposed to the federal law, which just requires an initial in-person visit. Alaska is an odd one. It aligns with the federal requirements, but opiates can only be prescribed 7 days at a time. Georgia, no controlled substances for pain treatment, but other Schedule II substances like ADHD medications, for example, would be fine. Maryland, no opiates for pain via telehealth unless the patient is in a healthcare facility. So they could call in from a facility to get a prescription. North Dakota, just categorical opioid prohibition, no prescribing opioids via telehealth, but again, other Schedule II substances are fine. West Virginia, no Schedule II substances for telehealth patients unless there's a pre-existing patient relationship. And so I don't just need an initial visit. You have to have already established a relationship with the doctor beyond just that issue. So the key takeaways we found were there's some tension between federal law and state law. The Ryan-Haight Act is a floor, not a ceiling. So again, this research is mostly targeted towards telehealth providers. So what we are telling the providers we work with is that it is a complicated patchwork that they need to know how to navigate. And there is not a single compliance framework that providers can rely on. It is important for providers to have an individual analysis state by state. These rules are in flux, as you all know. I think the last DEA waiver was granted at like the 11th hour. We were texting on like New Year's Eve about whether or not they were going to grant the waiver. So I wanted them to come in at like literally like after 11 p.m.
It was late.
Yeah, it was quite late. So providers have to be prepared for the rules to change soon. Because I'm not sure how many more times, if any more times, the waiver will be granted. Hopefully, it will continue to be granted. So state by state analysis is essential for providers. This is just a broad overview of state laws. This is like a 100-yard overhead view looking down. It's a starting point for legal analysis, but it's not a substitute for legal analysis. So it's important for providers to look more carefully, and you can always get in touch with the CTeL if you have any more specific questions. We're happy to help you out with research. Are there any questions for me right now? I would say, I would hope we'll have it out by the summer. The research is done, but we're sharing it with members to take a look at it, give it a pass over. Make sure no one has any like major feedback. I would like to start, I'm saying by summer, I would like to get it out sooner than that. Maybe by, what is it now? It's almost April. But yeah, by end of May, so summer, I guess. Thanks very much, everyone.
Do we have any questions on state laws any of the state laws for Sophie? All right.
Can I make any chat?
Oh, yeah, we might, yeah. Just, what is that?
Not hearing this coming.
Oh, okay.
Actually, I have a question.
Yeah, it's Robin.
We talked about payment parity, at state level. Previously, do you have a sense, even just a rough sense, about how many states have payment parity?
That is something I would have to look more into. I didn't look at payment parity for this survey.
Yeah, Lydia.
Yeah, we published a similar sort of 50-state survey on payment parity. We found that there's not quite a third split, but there is definitely a difference between coverage parity and actual payment parity. There are a lot of states that only had coverage parity. There were about a third states who had full payment parity, some coverage, and then some neither.
I see. Very cool.
You want to define what coverage is versus payment?
Sure, yeah. And just to clarify, when I say coverage parity, mandates that telehealth services must be covered, but not necessarily at the same payment rate as an in-person visit.
So now that we've discussed research, we shared our research with DEA, we shared it with HHS, we actually met with the Secretary's office in June, provided a formal presentation to the Secretary's team. We have shared it with all major agencies, and Congresswoman Matsui last June co-hosted, which is very unusual. I felt so strongly about this, co-hosted a briefing with CTeL that Scott presented at. And so the information is shared. DEA, Congress, and all relevant agencies have access to what I would consider an inaugural study. There's nothing really like this that exists right now to look at diversion and telehealth. We know there needs to be additional studies, but this is a good first step in terms of the body of research. And, we believe that it gives DEA information to operate off of. Scott, do you have anything?
Well, you sent it to them. They may be looking at it, using it. I just don't know. What they're, and I would keep pushing for a meeting with them.
Yeah.
Just keep emailing them, and hopefully they'll give you one. I know that they're sitting in, after the notice of proposed rulemaking comment period are done. Very rarely do agencies meet before they publish the final rule, and I think that's the hurdle you have to get over to keep pushing. This is just, we're gonna talk. You just listen, and they'll ask some questions even though they're not supposed to.
Beth, I'd love to get your opinion. So we've shared this with DEA, all relevant agencies. What do you think our strategy should be with ONDCP and the White House. Is there anything that we should do differently in terms of information sharing?
I think one is to definitely meet with OTC if you haven't already.
Mhm.
The medical director, the head of public health there is back from, she was in the first Trump administration. She is an addiction doc. So perhaps you'll have a more of a welcome there. I know that their public health team unfortunately has mostly left, whether it be through RIF or retirement. So mostly my whole team is gone. So I think that that doesn't bode well for what the agency might be focusing on now. Also, in the first Trump administration, they were very, very much more concerned about public safety rather than public health.
What's the difference? Explain that to us in
So-
terms of policy setting.
In terms of it was more about diversion control. It was more about that side of than it was about expanding access to medications. That was more the public health, like how can we be more cognizant of the needs of the patient rather than the needs of the law enforcement community. So we're seeing a shift at ONDCP back towards that law enforcement approach rather than more of a public health approach. Essentially, with the first Trump administration came in, they dissolved the Office of Public Health. And then when Biden Harris administration came in, we rebuilt the Office of Public Health. And now the Public Health Office is pretty much gone once again. So I think that is probably also one of the issues is that, you know, folks aren't gravitating toward information that would talk about patient access and patient experience. One would hope that this would resonate more with HHS, especially because HHS and DEA do have to work on the rule together technically. But I also think that they've also had such a brain drain, and that this concern is really taking a backseat to a lot of the other focuses that the HHS secretary has, which are, this is not part of their, it's also concerning in Congress. And this is just sort of something that I was mentioning earlier before we started. In the Senate, and this is just sort of one microcosm, right, of what's going on. But in the Senate, they just issued their guidance around earmarks, congressionally directed spending. And they have restricted the number of requests that senators can make regarding mental health and substance use disorder projects to a very tiny amount. Which is, that like jumped right off the page at me, and it's incredibly concerning that as we talk about the opioid crisis, as we talk about folks saying, you know, Adderall is the next opioid crisis, we are then taking all of these projects that could help the local level and saying, sorry, we're gonna limit you to a very tiny amount. So it says to me that somebody's saying, well, we don't need to worry about that anymore. So how do we keep this front and center when, because we're talking a lot about fentanyl, we're talking about illicit fentanyl, we're talking now about it coming over from, you know, every, I'm gonna stop there, but we won't edit, I'll edit myself. But we're talking about the illicit fentanyl trade rather than talking about the public health side, which is how are we addressing people at the community level and getting them access to care. And this, the congressionally directed spending in the Senate sort of just highlighted that for me in a way that was sort of like, wow, I guess you think it's all over.
Scott and Beth, I'm wondering if you could tell us a little bit about some inside baseball that happens within ONDCP versus DEA. And the goal of this conversation is for intelligence sharing. CTeL's already presented its research to all the relevant agencies. We presented the research to ONDCP, but before it was published, we provided information to them. So it would be great if we could potentially get a meeting with them, but for this administration in this current scenario, who has more pull? Would ONDCP have a conversation with HHS? I know traditionally DEA and ONDCP have had a tug of war over authority. What is the role ONDCP would play in this scenario?
It's hard to know because given that, so ONDCP has published a national drug control strategy. And the national drug control strategy that was recently published is much more, was very tiny. First of all, ours was very large, but also it was very light on the public health side and more on public safety side. And again, ONDCP is going to position itself in this administration as more of a public safety or law enforcement agency, which is not technically their role. As being law enforcement, that is the role of the Department of Justice, which is where you all sit, DA, so there is that tension is like, who is the law enforcement agency? And ONDCP is not. They are to be the advisor to the executive office of the president on matters of drug control policy. So a policy agency, not a law enforcement agency. And it's unclear, given the National Drug Control Strategy was written for the most part prior to the confirmation of the new director of ONDCP. It's not clear what her goals are. She has not really been public. In fact, I've hardly seen her out and about. So I'm not quite sure. It's hard to tell what their actual, what she's mandated of them. But I'm pretty sure that it's not public health focused.
Would it be helpful if federal agencies heard from notable state actors? So like, for example, the National Governors Association, we have Federation of State Medical Boards here. We have Interstate Medical Licensure Compact. It would, as we think about strategy, would it be helpful if White House and DEA and HHS collectively heard from these state actors saying this could potentially be very bad for our prescribers and our hospitals and our health systems? Nora, you represent hospitals in Texas, and you have such an amazing relationship with those in Texas. Like, what is our collective thought about putting together some type of letter that is signed on by, state representatives?
I think one agency we haven't talked about is the Domestic Policy Council. They have not been very active as they have been in the past. I mean, we had in the prior administration, we had a very active Domestic Policy Council. Yes.
Yeah, I was always
right
with you guys.
Exactly. So I think that's one place that would benefit from hearing a lot about this, because they are the convener, they do give the direction. And so they have been in the past. But I think they would be a key agency to really get in front of. To me, that would be one, and maybe they would punt it to ONDCP or HHS, hard to tell. But they're in a lot of the agencies right now, like HHS is in a lot of chaos, as everybody can read in the paper. I'm not saying anything out of school, with regard, who's gonna head up the CDC, who's gonna head, all the different agencies. There's sort of a lot of musical chairs going on right now. So also that does not help any organization or any, policy initiative that needs to be decided and discussed. Is when you're playing musical chairs constantly, there's no focus. So the chaos does not help anybody.
Right, you don't have continuity for delivering on projects, and so things get lost pretty quickly, as we saw in December.
And also, I agree 100% that DEA is a law enforcement agency. So the people who are writing this have spent their whole career seeing how bad this can go. So they don't want that to happen, so these are the people writing it. And then you have the public health side that is completely the opposite. They're like, let's just make this stuff flow because it's going to help patients, and that may not be true. I know that there was a huge contention between DEA and HHS, and I don't know where ONDC people fell into that, over the buprenorphine rule, where you can do an audio only phone call. DEA is like, that is recreating the opioid crisis times 10, because how do you know who you're talking to? How do you identify this patient? How is you as a doctor, can you establish a doctor-patient relationship, which is the key for DEA, over a phone call? So diversion was so set against that. And that's just as a law enforcement agency, because we can see, because this is what we've done all our lives, how bad and how south that can go. But HHS on the other side sees the health benefit of this, and law enforcement isn't their focus. They don't, they want it to be safe, but they'd rather get it out to the patients to see if it helps. You know, so there's this huge clash constantly between the agencies. And now under this new administration, DEA is also in chaos. They have a new administrator who has never in his career worked anything involving diversion. And you could see it by the priorities he put out to the public. There is nothing diversion pharmaceutical related in those priorities. Telemedicine definitely is not in it because he's probably just not even aware of what the issues are with telemedicine because that's not his wheelhouse. You know, DEA's out playing policemen in Washington DC. They're out on the border. They're out helping ICE. You know, they're all over the place. So it's just not a priority, which even makes it harder.
Can we step back to the state, maybe a letter that is signed on by state actors? I know that those of you around the table can't give an answer to that, but do you think that there might even just be potential appetite to send a letter to HHS and DEA, and DCP, and Domestic Policy Council saying, you know, this is going to have a major state impact? Nora, you've got your hand raised. What do you think?
Yeah, so a couple things. So the NGA, RGA, DGA nexus is a real thing, and the administration in general will want to know what they think. But I also think we need to at least shore up the gap, if not win them over, with groups like Cicero Institute and Paragon Institute. Paragon is driving policy in the White House right now. Paragon are the people that help structure the Medicaid cuts in OB3. So we need those folks, and I'm being really pragmatic and on the brink of cynicism here. We need those folks at a minimum to be neutral and at a maximum to be supportive, because on some of the other areas that I work with, like I work with Cicero and I'm watching this stuff with Paragon because it's impacting my state. There are people in this administration who want to know what those think tanks think. And so I think formally getting the Governors Association support is important, and I would encourage that approach. But I also think, I dropped in the chat and I don't want to rabbit hole on it, Cicero, which is funded by Joe Lonsdale, is pushing this AI framework. They just asked me to have lunch to see if my group's going to sign off on their AI prescribing framework that they are presenting. And I'd like to know where they sit on the issue that CTeL is talking about today, because I don't want to be working with them in a vacuum. I want them to look at the big picture of what they're doing. And I also just very sort of political radar thinking, the people that are making decisions way up here are listening to some of these external groups that didn't even exist a few years ago. So assessing where they sit vis-a-vis our issues and seeing if we can't at least get them to neutral can't hurt and might help, because that's who is going to be asked, well, what do you guys think about this thing over here, this thing over here? And I'm feeling the ripples all through Texas. Cicero has been very successful on some non-telehealth issues at the state level as a Republican think tank that didn't even exist, like I said, a few years ago. I do like the letter idea, Krista. I'm saying both. Yes to the letter. I think that has value, but these think tanks need to be on everybody's radar as well.
And Rick might be on with us virtually. Rick Masters or Marshall Smith, representing the Interstate Medical Licensure Compact, and we've got Lisa here, Lisa Robin, with the Federation of State Medical Boards. There is an impact on boards and licensure, especially if you are prescribing unknowingly in an inappropriate way. Your license gets revoked, and as Rick will tell you, when he joins us, is that you do wrong in one state, your license gets revoked in all 30 plus states. And that is a big problem, because even if you, and it's going to take a while it's going to take a while to adjudicate that. It's going to take a while to get your attorneys in front of the right people and to get your license back. So we're already in a clinical workforce shortage, especially with prescribers that can prescribe controlled substances. We don't want to, put them on the bench, so to speak, because they got misinformation. Lisa, do you have any thoughts about that?
Well, I do think medical boards are definitely impacted, and as a federation, we even have policy on access to treatment. And I hate to be so skeptical, but I really did wonder if a letter to these agencies, if they are going to care at all, because I agree. I don't think that this is their priorities right now. Look at everything. It's much more law enforcement than public health driven. I am really interested though, I'm very familiar with Cicero because Cicero, they're pretty influential. And they're influential at the very state level because they're doing a lot of stuff on health workforce as well. And I think that they are a policy group to reckon with. We've had some interactions mainly on looking at, they're very much into additional licensure pathways and bringing, they're looking and bringing, people in from other countries and whatnot. But, and I can see that doesn't surprise me about this AI and prescribing because you've already got this thing going on in Utah, which is really interesting, I guess.
Nice way to say.
And how this is really snowballing, and the current concerns that our boards have is that it's all happening in these state laws with these sandbox laws, which I'm not really sure where they're coming from, but maybe they're coming from Cicero. I'm not sure, but they completely leave the medical boards out of the picture, and probably the pharmacy boards as well. I don't know that for a fact, but so it seems to me we might have more. It might be more effective to go to some of these policies, think tanks. I'm not really familiar with Paragon as much as I am with Cicero, but I do know they're pretty influential. They've got model legislation out there and they're pretty good at getting it passed.
So Paragon, Cicero, Heritage, and get in front of them and educate them on policy issues that this is, Republicans are the state, they advocate for state rights. And this might be a good opportunity to educate at the state level.
Well, sort of state rights. They also advocate for preempting state rights.
Yeah, they're not terribly consistent. They want to deregulate when it suits them and they want to regulate when it suits them, which I think is sort of the baseline nature of any think tank, right? They're going to advocate for whatever approach might get them the thing that they want. I do think that they are so new relatively that they may not even be thinking about this particular space. So I do think there might be an opportunity to talk to them, especially since people like Cicero are advocating for basically the AI to get a medical license. That's what their document says. So enjoy reading it. It's very interesting.
Joe made mention that we should include the state attorney generals into this group. That's really brilliant and actually very obvious. That I'm sorry I didn't think of that. Is that we should. I mean, they're the ones bringing action against these companies.
Can I add to that? So when we were working with Congressman Paco's office to pass the act to reverse the Data 2000 waiver to increase access to buprenorphine, we partnered with the National Association of Attorneys General in our efforts, and they were very supportive. They are ones that will take a meeting and listen to the information. I can see how a lot of this, it makes their life miserable when every state is doing something different and you got people going back and forth, and they're contending with hospital systems and prescribers that are in different states yet prescribing or having patients in multiple states. They, as a group, NAG does, they may endorse individually, but if a majority of their members will consider something and support it, then they will support it as an organization. So they did have a number of both red and blue states that were supportive of eliminating the Data 2000 waiver. And so they joined with us when I was at Pew, and then when I was at the White House in helping to pass the legislation. So I think that Joe's a great idea.
Do you have a contact at State AG?
I will ask. My contact is now in Georgia, but I will ask.
Does anyone else have a contact here that could do a warm introduction?
With them, and I haven't in the last
I can look because we were part of that.
Yeah.
That
It was
works.
Ryan, it was Ryan.
It was Ryan, yeah.
I'll call Ryan.
Yeah, but there was another woman who took his place, but it's been a while.
It has, right? Yeah.
Yeah, but they do have a history of, we even worked with them on 42 CFR Part 2, so they have a history of substance use disorder policies that I think some people might be surprised with, but they were helpful in our legislative work, certainly. Especially talking about diversion, because when we would be on the Hill, they would say, well, we get our, we have offices say, well, we talked to DEA, and we would say, well, here's this research, right? So it's helpful to hear kind of that backstory a little bit on that, but I do think it's a great idea. It's a great idea. And the other thing I was gonna say too, not to take it back away from the state, we don't do as much state work, but I think the Domestic Policy Council is someplace I think we would want to press on this and maybe tying it even though it might be a stretch somewhat, there is an executive order on the Great American Recovery Initiative that's about, right, trying to address substance use disorders. And so I think you kind of have to make those connections in certain ways, that this is all kind of under the umbrella of, from our perspectives, right, we're looking at treatment, and so, and access to treatment. So that may be the way. I think they're getting, agencies in other areas of policy that we've been working on, getting their direction from domestic policy, their priorities, right? And so they may have interest in things, but it's coming from the White House. And so they're not, if this is not on an agency priority list or focus, starting, I think, at the White House might be helpful. And I don't mean to negate some of the other think tanks, because those are certainly, pushing kind of that policy, but I would think about it that way too.
Joe, you mentioned AMA. I don't think AMA is on the call with us right now, but American Hospital Association is here. They have two representatives, Robin and who's here, our other colleague. Okay. Oh, there you are, Caitlin, over in the corner. Yeah, I mean, this is something that, the American Hospital Association has so many amazing state associations that we could potentially get a letter together. Would that be something that you could run up to leadership?
So AJ doesn't sign on to letters, the individual state associations sign on to as well, just because there is overlap there.
So states sign on, but not the
right. So
national.
it's kind of one or the other. So if individual state associations sign onto a letter, then we would decline to sign on to it, just because it's kind of double debate.
Got it.
For us, although we do obviously work very closely with the state hospital associations in a lot of several different ways that we could use as either information sharing or gathering or asking what they're seeing at the state level and gathering information around state legislation. I would also mention, going back to the state attorneys general or the governors associations, we do have a pretty robust state national partnership initiative, I guess you would call it, where we are looking for ways to bolster the relationships that we have with the national organizations that work on state issues. And so there are a couple of forums that we have to, I don't want to say insert ourselves, but get feedback and bring these issues up to the forefront of those. So that's an opportunity, that may be an opportunity as well.
So practically speaking, what would next steps be with AHA?
Well, I would bring in my colleagues who do work on the national state partnership, because we have, we'd have to run it up that flagpole, Ron, you can correct me if I'm wrong too. But in terms of what a letter might look like, we would shop that around with our leadership as well.
Okay. And then the other piece to this is we can't ignore hospice. Hospice is going to be just as much as mental and behavioral health is going to be completely impacted by it. And I believe we have Dr. Sheets on the phone. Do we? Or she may have left. April, is she still on? Jennifer, are you?
Yeah, I'm still here.
No, Jennifer. Okay. Well, the other piece to this too is that hospice is going to be negatively impacted. And we talked a lot with different hospice companies that were very concerned in December. So there might be opportunity to work with NAC. It sounds like Jennifer might be offline for a second, but when she comes back, let's raise this with NAC.
I have a question.
Yeah.
If you don't mind. Hi, I'm Rachel Tetlow with the OBGYNs, and I admittedly don't have as much background on the DEA side of things, but and forgive me if I missed this in the beginning, but I feel like we may have skipped over a little bit some of the potential headwinds at HHS, and I'm wondering if we should talk about that for a moment. I mean, I know we're dealing with potential, well, a lot of strong feelings about SSRIs, and I haven't talked with folks there about how they feel about opioids or buprenorphine, but I know that there, it's a real strong bent against medicating, and like with the MAHA framework, if there is maybe an assumption that they're gonna be kind of like, yes, they're in chaos, but they are on board with the public health benefits, and I don't know if we can make that assumption anymore. So I'm wondering if there may need to be some like even more baseline education, because I don't think that that common understanding necessarily exists anymore. But so I just wanted to raise that because I think that may provide a bigger challenge than we may think. And it may be that there are some folks that totally on board, don't need that, but there are others who are, bobbing around at FDA and are looked to for their thoughts on this and are gonna potentially be pose problems for leaders through that process.
Rachel, thanks so much for raising that. I'm going to turn it over to our speakers or to the panel. What are your thoughts on that?
I mean, it's true, there's chaos going on, and it's not clear what, in the MAHA, I mean, there's lots of things, but some pieces that are overshadowed other pieces. There are still a few and folks who left HHS, and that are still there, that, especially in the SAMHSA world, there are folks that are still there that still get that. Whether or not anybody's listening to them is a whole other story. With the elimination for 24 hours of all the SAMHSA grants to states, like all of that reads that this lack of understanding about what really happening on the ground, whether or not it was a mistake or not. But the chaos, generally speaking, it's not even clear, like if we're to educate folks, like how long will that last? Because the next round of chaos will happen, and there will be new people. So I do think though the Domestic Policy Council is probably first, because my experience at the White House was that when DPC said something, everybody fell in line.
You think that's still the case, even with the MAHA elements at HHS?
I think there's enough that the White House says things the way things are acting on.
Somebody may have already said this, but it occurs to me that the emphasis on telemedicine and telehealth in the Rural Health Transformation Program should be an asset for the argument that we're trying to make. Because why would they kick the legs out from under something that we need for our rural populations in the middle of having to spend all this money that is, at least as I understand it, supposed to measure outcomes, actual outcomes, services delivered, all these things for our rural hospitals. Again, in these care deserts where the rural hospital is the hub, taking away telemedicine and telehealth is not concurrent with what they put out in the notice of funding opportunity or the notices that most of the states put out about their strategies. It's certainly a top level strategy in my state, and I know that it is in others. So maybe there's a hook there if we can get to somebody who cares about our HTP to say, hey, you may not be thinking about the fact that these things are contradicting each other internally, but they sort of are. So pick our side and help us like work this out. I'm way exaggerating a very difficult conversation, obviously, but the siloing means they're not talking to each other, right? The siloing means they're not necessarily thinking about the fact that if we gum this up over here, it's going to hurt this thing over here. And so I think as external stakeholders, that's our obligation.
Well, and I think
to at least
honestly, I think you could take that even one step further as well on the rural access. And that was what I was trying to say to get in earlier, and then the conversation switched to another topic. But what I've seen really resonate so far with my meetings directly with the White House and then directly with HHS is two things. Number one, obviously there's a focus on fraud. Everybody's brought that up across the board. There's a focus on fraud, and we are seeing that. Certainly, obviously, home health and hospice has a lot of attention right now, and what we're seeing under those fraudulent actors are things that we've been talking about earlier: the theft of MPI numbers, the theft of Medicare numbers, there is a large part of this scheme, which is diversion of narcotics to then push out to the cartels. And so we've seen that, unfortunately. So that's part of the focus. But what I've really seen resonate